Hey everybody, and welcome back to another video here at Whiteboard Medicine. We appreciate you checking it out. Hope everybody's having a good day. Today we're going to be diving into acute respiratory distress syndrome, ARDS, ARDS, advanced management strategies. So this is going to be part of our ARDS video series. We've come out with a whole bunch of videos on ARDS. They're all in the ARDS playlist linked in this video's description, ranging from introductory concepts to overview concepts to advanced concepts. So definitely check that out if you have an interest in learning more about ARDS, or if this lecture is, too advanced, or if you need more background learning, we have a couple basics or introductory lectures in there too. So definitely check that out. Check out our Patreon page. We post practice questions, all the study outlines, daily kind of tidbits and musings on there. So we would love for you to join our Patreon community too. That'll be linked in the video description. No further ado, quick 30-second break for the introduction, then we'll dive into advanced management.
Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.
All right, thanks for sticking around. So, acute respiratory distress syndrome, advanced management. Well, when it comes to ARDS, unfortunately, there is no magic bullet to fix ARDS. Really, a lot of the care here is supportive care, with some caveats, all right? The big things we're going to talk about is ARDS does have some guideline management, but it also has some very big trials that guide that management. So in this video, we're going to be talking about lung protective ventilation, cc's per kg, plateau pressure targets, driving pressure targets. We're going to talk about the evidence behind prone positioning, conservative fluids, steroids in ARDS, what timeline they need to be given it by, preventing desynchrony and the idea of paralysis, and kind of two big capstone trials related to that. We aren't going to be diving as much into inhaled pulmonary vasodilators or VV-ECMO. When it comes to inhaled pulmonary vasodilators, these are medications that the patient inhales, and they cause vasodilation of the pulmonary vasculature that the medication gets to when they inhale. So the thought here is this helps the VQ match, right? You're going to vasodilate the blood vessels that are only adjacent to the alveoli that are functional because you're inhaling the medication. If an alveoli is all collapsed down, when you take a breath in, none of the inhaled pulmonary vasodilator is going to get to that collapsed alveoli. And as such, that collapsed alveoli's blood flow is not going to increase from the vasodilator. Whereas the alveoli that are open, when you inhale the pulmonary vasodilator, will get to those functional alveoli and will vasodilate the blood vessels around the functional alveoli, which will help with gas exchange in those units that are functional. With that being said, though, there have been no trials to suggest that this improves kind of mortality or overall outcomes. It does seem to improve hypoxemia or oxygen levels. But what to do with that after? This is a bridging therapy. This is a transient therapy that you need to then, get to the next step of care, whether that is, improvement, or whether that's someone you're trying to get to VV-ECMO perchance. The other thing we're not going to dive into as much here is VV-ECMO. We've talked about VV-ECMO in the past. We probably will come up with another video on it too if you're interested, but check out our critical care medicine playlist, and you'll get into some of the discussion on VV-ECMO. But for the sake of this lecture, we're going to dive into an evidence-based strategy for advanced management of ARDS, starting with some of the introductory concepts and then diving into many of these trials. There's definitely guideline-driven management endpoints, but there's some gray as well, depending on the intensivist or critical care doctor that is managing the patient and what trials they think are the most robust, et cetera, et cetera. So we're going to go over a general approach here, and then we're going to go over the big landmark trials that support this approach. So the general approach that you'll see in most guidelines when you're managing ARDS have to do with the ventilator, right? The ventilator is what that looks right. Ventilator is what is supporting these patients with ARDS because their lungs are so sick they're requiring invasive positive pressure ventilation in the setting of a ventilator. And the management strategies tend to be how we are changing the settings on the ventilator to best support their lungs. The challenges here being someone on a ventilator can get barotrauma, which is that their lungs experience such a high pressure from the ventilator that they get additional lung injury. You can get volutrauma, which, as the beginning might suggest, this is when you're getting high volumes from the ventilator. It can damage your lungs. You can get something called atelectotrauma and atelectotrauma. I don't know if that's how they spell it, but that's how we'll spell it today. Atelectasis is where certain parts of the lung collapse and then re-expand back open. And this collapse, expand can injure the lungs as well. So the settings which we're targeting on the ventilator for a patient with ARDS is trying to prevent or minimize all these different things best we can. So the general approach starts with the tidal volume. The tidal volume is the amount of volume the ventilator is pumping into the patient's lungs, right? It's the volume of air with each breath that the ventilator is giving the patient. And the approach for ARDS is you want to try to stick between 4 to 8 cc's of oxygen per kilogram, patient's weight in kilograms, of their ideal body weight. So if they're obese, you don't count their actual kilograms, you look for what their ideal body weight is. And you can find the ideal body weight calculation all over the internet. If you want it easy, MD Calc is a website that you can go to and find ideal body weight. And most would say you actually want this even lower, 4 to 6 cc's per kg of tidal volume per ideal body weight. And that is to try to prevent some of these things like volutrauma. All right, volutrauma being if you are having higher volumes on the ventilator. Let's say instead of 4 to 6 cc's per kg, you're giving 12 cc's per kg. It can cause volutrauma and damage the lungs. So you want to stick between kind of 4 to 8, 4 to 6 cc's per kg. You don't want the respiratory rate on the ventilator to be set to more than 35, so less than or equal to 35. And the reason for this is somewhat outside the scope of this discussion, but it has to do with breast stacking and ventilator compliance and those types of things. You want this entity known as the plateau pressure, which is a setting, not a setting, but it is a variable that the ventilator gives you. And it's the amount of pressure the lungs are experiencing after a full breath. And we'll talk more details about plateau pressures and peak pressures and things in a separate video. But just know your endpoint is you want your plateau pressure to be less than 30 millimeters of mercury. You want your oxygen saturations between 88 to 95%, some say as high as 96%, and you want your pH to be about normal. If you're not meeting these goals, specifically this plateau pressure goal, because the plateau pressure being less than 30 is hopefully minimizing the amount of barotrauma the lungs are receiving, aka the amount of trauma from high pressures in the lungs. So keeping the plateau pressure low is hopefully preventing that barotrauma. If the plateau pressure goes too high though, so if the plateau pressure increases above 30, typically what we'll try to do is decrease, arrow down, decrease the tidal volume by 1 cc per kg until that plateau pressure drops to less than 30, right? One of our endpoints of care. This is as long as the pH remains above 7.15, and this goes into some permissive hypercapnia or allowing higher carbon dioxide levels in the blood to achieve these things, which again, lots to ARDS management, and we're not going to talk about that part of it here, but let us know in the comments. We're happy to make a video on it. So this is our general approach, right? How did we come up with that general approach though? And the way we came up with this general approach has to do with the different landmark trials, and that's what we're going to talk about now. All right. The first landmark trial was actually back in 2000, so I guess a ways back now, but it wasn't, back in the 1950s. It was in 2000, and the trial's name is this ARDS Network Trial, and it looked at tidal volumes and plateau pressures. And what they did is they randomized patients to either get the 6 cc's per kg and maintain the plateau pressure less than 30, or to get 12 cc's per kg, so higher tidal volumes, and allow the plateau pressure to go as high as 50. And what they found was that in the low tidal volume and low plateau pressure group, there was a decrease in mortality, 31% compared to 38%, and an increase in ventilator-free days, aka how many days patients would spend off the ventilator, which is a surrogate for lung improvement. And those patients were off the ventilator for 12 days compared to 10 days in the 12 cc's per kg group. So those in lower tidal volumes and lower plateau pressure groups had a decreased mortality, and that is how we came up with this kind of 4 to 6 cc's per kg of tidal volume, ideal body weight, with plateau pressures being maintained at less than 30. It was from this trial here back in 2000. All right. Then we talk about another management strategy, and that is the PEEP and the FiO2. The FiO2 is the fraction of inspired oxygen set on the ventilator, and the PEEP is the positive and expiratory pressure, which is a setting on the ventilator which determines kind of how much is baseline pressure the ventilator is giving those lungs. Again, diving into PEEP a little outside the scope of this discussion. But they actually studied different PEEP settings in a trial known as the ALVEOLI trial, and it was done in 2004. And the PEEP settings they looked at, I actually will pull up here. All these articles will be linked in the video description. This right here is the first one we just talked about, looking at lower tidal volumes as compared with traditional tidal volumes. The ARDS Syndrome Network Trial back in 2000, as we mentioned. This is the PEEP table trial that we're talking about right now, higher versus lower positive and expiratory pressure in patients with ARDS. And they used these different tables, and they compared patients who were randomized to get lower PEEP and higher fraction of inspired oxygen, or higher PEEP and lower fraction of inspired oxygen. And these are the exact tables. They're on the ARDS net. I always recommend that those working in the intensive care unit have these tables handy, because you can literally just go right off the table. This is, if they're on PEEP of 14, you want their FiO2 to be no lower than 0.7, all right? You can then drop the PEEP to 12 to 10 with FiO2 staying at 70%, but once you get to 10, you then drop the FiO2. So this is kind of weaning tables with how you can weave through changing the PEEP and FiO2. But the good news is that this trial found that there was actually no mortality difference between low PEEP and high PEEP, no difference in ventilator-free days, which is why we can use either of these tables, right? Because the two groups had similar outcomes between low PEEP and high PEEP. All right, and that was the ALVEOLI trial that determined that. Another management strategy we use is proning. This is when you flip the patient and lay them on their stomach, often for 16 hours is one of the protocols. So proning in ARDS is something we do as well, based off of a trial known as the PROSEVA Trial, published in 2013. And what they did is they took patients with a P to F ratio of less than 150. Right? If we go back up to the Berlin criteria, P to F ratios here, less than 150 is kind of moderate to severe. Right? Moderate's 100 to 200, severe is less than 100, and they did 150. So kind of moderate to severe patients who are already on some of these therapies for ARDS, right? Tidal volumes, 6 cc's per kg, blah, blah, blah. And they flipped them onto their belly for 16 hours a day. And they actually found a significant decrease in mortality in patients they did that to. So a decrease in 28-day mortality and 90-day mortality. 16% in those that got prone compared to 32% in those that didn't. 23% at 90 days mortality in those that got prone compared to 41% in those that didn't. So proning is another thing we do in patients with ARDS who have a PDF ratio of less than 150. Flip them onto their belly, some tummy time, based off of this PROSEVA trial. Another management strategy that can be considered is neuromuscular blockade, or paralysis. And paralysis is when you give the patients a medication that completely paralyzes them. So they have to be deeply sedated so that they don't experience and they're not lucid for any of this. Neuromuscular blockade, though, is something that's done, but the trial evidence is a little bit mixed. So the first trial, the trial that got everybody excited for this, was the ACURASYS trial in 2010. And they looked at patients who had ARDS, enrolled them within 48 hours of their diagnosis, and you had to have a P to F ratio of less than 150. And they found a decreased mortality, a mortality of 31% in those that got paralyzed compared to 41% in those that didn't. But it was a smaller trial, And more recently, in 2019, just a few years ago, there was the ROSE trial that came out. Same kind of enrollment criteria, PDF less than 150, 48 hours since ARDS diagnosis, and they found no difference at all in mortality, 42% and 42%. So many institutions, mine included, for patients who are very sick with ARDS, they might not be cooperating with the ventilator, and because of that, they're kind of on the cusp of potentially dying, will use neuromuscular blockade. But the evidence now that the ROSE trial came out is not in, it's kind of equipoise. You know, the ACURASYS trial found mortality benefit, ROSE didn't. With that being said, ROSE was a much larger trial. They did use light sedation in the control group, so deep sedation in those that were getting paralyzed. They used higher PEEPs in the ROSE trial compared to ACURASYS, so there was some differences here, but the ROSE trial was a much larger trial, so it is one that kind of you should digest with a little more confidence than the ACURASYS trial, which was smaller. All right, so what have we gone through so far? Let's just write them out down here. So we talked about the evidence for 6 cc's per kg of tidal volume, that ARDS network trial. We talked about keeping the plateau pressures less than 30, that ARDS network trial. We talked about how you can use either low PEEP or high PEEP, right, based off that ALVEOLI trial, and you can just look up these PEEP tables on ARDSnet. We talked about how you should prone patients who have a P to F of less than 150 based off the PROSEVA trial. And we talked about how you can consider paralysis or neuromuscular blockade based on the ACURASYS trial, though the newer and larger ROSE trial did not find an improvement in mortality, which is why we'll put a question mark for paralysis. So what 2 other things is there some evidence for? Well, one is a conservative fluid strategy. This was a trial from 2006, again, ARDS Clinical Network Trial, and they looked at patients who they kept about net neutral in their fluid balance versus patients that were very net positive. A median was 7 liters net positive. And although there was no mortality difference between the 2 groups, those that were in the conservative fluid group, so those that were kept about net neutral, had more ventilator-free days and spent less time on the ventilator. So there is some rationale, even though there's no mortality difference, in keeping patients closer to net neutral if their other pathology will allow it, compared to allowing them to be very net positive. So keeping those patients, quote unquote, a little bit dry. And then last is steroids. And steroids is something that some institutions do, some don't. But there's been many trials, many of them small, looking at steroids. In 2020, though, there's actually a larger trial called the DEXA-ARDS trial. And they enrolled patients with a P to F ratio of less than 200. And they actually found in those that got steroids, there was a mortality benefit, a decrease in mortality, 21% in those that got steroids, compared to 36% in those that didn't. There was also more ventilator-free days in those that got steroids, 12 compared to 7. And that's some fair evidence. So I would put conservative fluid down here as reasonable, although with the understanding that there's no mortality benefits, so don't harm patients by doing it. And steroids, I think, probably are going to become more widespread in ARDS treatment because of this newer DEXA-ARDS trial. So if we flip on over, we'll link all of these trials in the video description. Here's the PROSEVA prone positioning trial. Here's the ACURASYS neuromuscular blockade trial, ACURASYS, which showed benefit. But here's the more recent ROSE trial that did not show benefit with paralysis or neuromuscular blockade. You can see ROSE trial down here. And then we have the conservative fluid management trial. And then last, this DEXA-ARDS trial. So most of these published in very high caliber journals. These are a lot of the trials that are quoted in the guidelines and the trials that anyone interested in this topic should probably be aware of to help inform their management strategies and practice. We know that was pretty complex, pretty dense. There's a lot there, and we left out some of the introductory knowledge just because it would have been a 6-hour lecture if we dove into each small thing. So let us know what thoughts, questions, comments you have down below. Let us know if this type of video is interesting or helpful. It's probably most interesting to a smaller segment of individuals in medical training, those interested in critical care medicine, rather than a larger population of you. So apologies for that, but hopefully even for everyone else, it was interesting as well. In any case, we appreciate you watching. Subscribe, hit that bell button if you feel so inclined. Check out our other videos. Stay well, keep learning, and we will see you all next time.